the doctor not to put disease asthma, but I don't understand why. Why? Because in children practice, we have cases of successful prognosis and results of treatment rather maybe rather good. Of course, what next picture you can see anatomy of an asthma attack. In pathogenesis of bronchial asthma may be several mechanisms of action, like laryngospasm, hypercrinia or dyskinesia and inflammatory edema, inflammation. Edema. Exist special cells which take part in pathogenesis of bronchial asthma. These are eosinophils, Th2 cells, basophils, neutrophils, platelets, mast cells, structural cells like epithelial cells, smooth muscle cells, endothelial cells, fibroblasts, nerves. And pathogenesis of spasm, of course, will be under influence of mediators like histamine, leukotrienes, prostanoids, kinins, adenosine, nitric oxide, cytokines, growth factors, and effects received. Effect is bronchospasm. This is production of mucus and structural changes. As for classification of bronchial asthma, maybe according to the frequency and severity of symptoms, may be mild, moderate, and severe. Informal categories like seasonal, exercise-induced, drug-induced, occupational asthma, asthmatic bronchitis in smokers, allergic bronchopulmonary aspergillosis. May be due to typical categories like extrinsic, allergic, region-mediated, atopic, intrinsic, idiosyncratic, and mixed intrinsic and extrinsic factors. Of course, exists another group of factors influencing on the development of asthma, like genetic factors, genes predisposing to atopy, genes predisposing to airway hyperresponsiveness, obesity, and sex. Asthma is the swelling of the airways and excessive mucus production, which causes cough and difficulty in breathing. When the swollen lungs come into the contact with any of the following, an asthma attack is triggered. Now in children, of course, furry animals and bird features, physical exertion, chalk dust in school, pollen from plants, changing weather, and strong emotions like laughing or crying. As for environmental factors, exist indoor allergens, domestic mites, furry animals, dogs, cats, mice, cockroach allergens, fungi, molds, yeasts, outdoor pollens, fungi, molds, yeast, infections, especially viral infections, passive smoking, diet, indoor, outdoor air pollution. In younger children, risk factors are sensitization to allergen, maternal diet during pregnancy. Of course, we recommend to all mothers to avoid some potential allergenously products, but they may not listen to us and think what to do if I wanted to eat what I like. Microbes and their products, psychological factors, in United Kingdom is one of the highest prevalences for childhood asthma internationally, with about 15% of children affected. The prevalence in 8 to 10 times higher in developed countries than in developing countries. What are the purpose of our treatment? We should make correct diagnostic. We should make the right choice of drugs. We should make schools for parents how to behave themselves with bronchial asthma. We should speak with parents not to afraid of steroid therapy, because when some parents listen that their child is recommended steroids, they have shock. And especially if child has obesity and bronchial asthma, such parents always say, "Oh, we receive hormone steroids. That's why my child is so fat." It does not depend on this. These are inhalated corticosteroids, and their obesity has no connection with inhalated corticosteroids. Some children cannot inform doctor or parents about their problems, and we know only poor anamnesis or anamnesis. Determination of PEF cannot be performed in children whose age is below 5 years old. Physicians' lack of knowledge and time. As for clinical features, here, recurrent wheeze, recurrent cough, recurrent breathlessness, activity-induced cough or wheeze, nocturnal cough, breathlessness, tightness of chest. Cough occur in 90% of cases, wheezing 74% of cases, and exercise-induced wheeze or cough 55% of cases. Typical features of asthma are afebrile episodes, personal atopy, or family history of atopy, exercise activity-induced symptoms, history of triggers, seasonal exacerbations, relief with bronchodilators. What is the rate of asthma? By 1 year, 26% of cases. The most part of all cases occur in such age period as 1 to 5 years old. And more than 5 years, 22% of cases. 77% of cases begin in age less than 5 years old. But as I'll repeat to you that some parents do not believe that this is asthma and begin to walk and visit several doctors. Tools to diagnosis: good history taking, careful physical examination, and investigations which may be performed above 5 years only. Spirometry is a pulmonary function test that measures the volume of air an individual inhales or exhales as a function of time. How to perform this method? For normal breaths, inhale as deeply as possible, exhale to normal depth. 3 normal breaths, exhale as much as possible, 3 normal breaths. Inhale as much as possible, exhale as fast and completely as possible, and 4 normal breaths. Spirometry can help us to make diagnosis, can help us to assess degree of airflow obstruction, to predict whether obstruction is reversible, to monitor progression of disease. Performed investigations. This is peak expiratory flow rate. It is highly suggestive of asthma when more than 50% increase in peak expiratory flow rate after inhaled short-acting B2 agonist. More than 15% decrease in peak expiratory flow rate after exercise. Diurnal variation, more than 10% in children not on bronchodilator. Below 6 years, we should make differential diagnosis to exclude another pathology. Physical examination. If the child does not appear acutely ill and is growing, and there is no evidence specifically indicating another course of symptoms, a trial of therapy is warranted. Trial of therapy bronchodilators. Improvement with treatment supports a diagnosis of asthma. Frequent reassessment. Healthcare professionals should always be prepared to reconsider the diagnosis if management is ineffective or if the clinical situation changed. How to confirm diagnosis of asthma? If the child is having 3 attacks of airway obstruction in last 1 year, 3 documented cases. If the child gets 1 attack of asthmatic symptoms after the age of 2 years, irrespective of age, in an attack in children with allergy, eczema, food allergy, or history of atopy. If the child does not become free of symptoms when infection does not have symptoms, when infection has reached or has persistent symptoms for more than 1 month. The goals for successful management of asthma are achieve and maintain control of symptoms, maintain pulmonary function as close to normal as possible, prevent asthma exacerbations, avoid adverse effects from asthma medications, and prevent asthma mortality. But I don't remember mortality or asthma mortality on my memory, how I work among children, I mean. Even with severe bronchial asthma, I don't know such cases. If age is below 4 years, pressurized melted dose inhaler plus dedicated spacer with face mask, or alternative device nebulizer with face mask. 4 to 5 years, pressurized melted dose inhaler plus dedicated spacer with mouthpiece. Nebulizer alternative with mouthpiece. Older than 6 years, dry powder inhaler or breath actuated pressured metered dose inhaler or pressurized metered dose inhaler with spacer with mouthpiece. Like alternative method is nebulizer with mouthpiece. The stepwise approach to drugs. Bronchodilator for relief of symptoms. Step 1, occasional use of relief bronchodilators. These are short-acting B2 bronchodilators as required, plus low-dose inhaled steroid for 2 to 400 milligrams micrograms day. Step 2, regular inhaled preventive therapy. Short-acting B2 bronchodilator is required, plus high-dose inhaled steroid or low-dose inhaled steroid, plus long-acting bronchodilator. Step 3, add-on therapy. Short-acting B2 agonist, high-dose inhaled steroid up to 800 micrograms day, plus long-acting bronchodilator, theophylline or ipratropium. Plus minus alternate day steroid. And step 4, persistent poor control. Use daily steroid tablets in lowest dose. Maintain high dose inhaled steroid at 800 microorganisms a day. Refer to respiratory specialist. Step 5, continuous or frequent use of oral steroids. Those are such 0 to 2 years old. Acute treatment, salbutamol, terbutaline, ipratropium. And like prophylactic treatment may prescribe budesonide via Nebuchadnezzar, beclometazone via Lunatic. Doses for 3 to 5 years old are more if you compare with doses for children whose age is below 2 years old. Almost in 2 times. Prophylactic treatment, administration of budesonide via Nebuchadnezzar, beclometazone, fluticasone, salmeterol, and combination inhaler Seretide. Contains fixed doses of all combination therapy of all drugs. If age is 5 to 12 years old, we prescribe salbutamol, doses more in salbutamol inhaler, terbutaline inhaler, prophylactic treatment, budesonide, trobehaler, beclometazone via Acuhaler, fluticasone via Volumetic, combination inhaler, Seretide contains fixed doses of fluticasone and salmeterol or Symbicort turbohaler. It does not mean if you have a third step of bronchial asthma treatment according to the first step bronchial asthma that you will forever have such bronchial asthma. When we see improvement of condition of the patient, we can decrease the step therapy. But you should remember that there exists such term like basis therapy. What is basis therapy? Basis therapy, this is administration of therapy to the patients who have bronchial asthma of moderate and severe stage. So such patients has constantly symptoms of bronchial asthma and should receive corticosteroids for basis therapy. Sometimes we give anti-leukotriene inhibitors. May prescribe in tablets, but should remember that such drugs like Zafirlukast, Montelukast, they have side effects, especially if child has attention deficiency, hyperactivity disorder. Administration of such drug like Montelukast and Zafirlukast may cause make problems with behavior of the child, and symptoms may progress very quickly, and sometimes we should we should stop therapy of bronchial asthma to improve condition of the child. Have you questions to me in bronchial asthma, doctors? If you have no questions, I wish you good day